stool softener makes the stool very soft. The laxative effect of the stimulant also propels the feces to be excreted. So that's why you combine the two, a stool softener and a stimulant.
Nine, co-danthrosate refers to fixed combinations of A, sodium picrosulfate and senna, B, dantron and senosides, C, docusate sodium and dantron, D, methyl cellulose and psyllium. A.
Okay, which one are we going for?
C.
Yeah, so C.
C.
So co-danthrosate. That one is a combination of docusate sodium and dantron. So the same way docusate sodium is stool softener, dantron is the stimulant.
Ten. All the following increase intestinal motility except A, senna, B, erythromycin, C, polycarbophil, D, bisacodyl.
But which one are we going for?
C.
Polycarbophil.
Yeah, so polycarbophil. So that's a bulk forming laxative. So the rest have a stimulant effect. So they increase intestinal motility.
(11) Why the use of co-danthroma and co-danthrosate are limited to terminally ill patients. A, risk of fecal impaction. B, risk of nephrotoxicity. C, risk of bezoars formation. D, risk of carcinogenicity.
Okay, so which one are we going for? What are you going for? So the co-danthroma and co-danthrosate, basically for patients who are terminally ill, those who are terminally ill and they're about dying, these are the patients you usually would want to give co-danthroma or co-danthrosate. This is because of the risk of carcinogenicity. So we don't give it routinely for other patients because of the possible risk of carcinogenicity. And for terminally ill patients, they may be on palliative care. So they may be on high dose of opioids. So you may give morphine, very high dose, 200 milligram up to even 600 milligram a day. So because of that, you don't want them to have the side effects of constipation. So you combine a stool softener and a laxative in that phase combination, co-danthroma or co-danthrosate. So usually because of the risk of carcinogenicity, when you use it long term. You don't want to use it in normal patient. But if the person is about dying and they need high doses of opioids, you can use those agents in them.
Twelve. Which of the following acts as both stimulant and fecal softener? A. Lactulose. B. Wheat bran. C. Docusate sodium. D. Liquid paraffin.
C.
Yeah, so docusate sodium is true. So it's a stool softener and also has a stimulant laxative effect. So you realize that some of these laxatives do not have just one mechanism of action. They may have multiple, but the predominant one for docusate sodium is the stool softening effect, but it has some stimulant effect.
Okay. 13. Typhoid pneumonia is a side effect of A. Spagular husk. B. Codanthusate. C. Liquid paraffin. D. Glycerol suppositories.
Which one are we going for?
C.
Yeah, so usually the mineral oils, the lubricants, they tend to do lipoid pneumonia, so liquid paraffin.
Fourteen. All the following can be used in opioid-induced constipation except A. Lactulose. B. Senna. C. Psyllium. D. Docusate sodium.
A.
I'm hearing A. Any other answer?
C.
C.
Okay. So is it A or is it C?
A.
Okay. So is everyone going for A?
A.
Is everyone going for A? So the answer is C. So for opioid-induced constipation, if we look at how the opioids cause constipation, basically they block peristaltic movement. So once peristaltic movement is blocked, you have the stool content remaining there. So the patient can be constipated because there's reduced GI motility. And this is caused by the opioids. So if you are given a laxative for opioid-induced constipation, usually the ideal medication are the stimulant laxatives because they would help propel GI motility. So they are the best. However, they are insoluble, non-absorbable, non-digestible. So if the peristaltic movement has been inhibited, once they swell up and increase the fecal mass, and there is no peristaltic movement to propel this bulk that has been formed, there is likelihood of blocking the GI. So the patient can present with intestinal obstruction because they took bulk forming laxative to manage an opioid-induced constipation. So that's the issue. So for bulk forming laxatives, you avoid them if there is opioid-induced constipation because they require peristaltic movement to be able to exert their effect. If there is no peristaltic movement, they will rather end up blocking the GI. So you avoid opioid-induced constipation.
Okay, Dr. Ishak, please, I want to just clarify something. Please, for the opioid-induced constipation, between the stimulants laxative and then the osmotic laxatives, you're saying that we should go for stimulants laxatives. So does it mean that like the opioid laxatives are not like preferred?
No, so we are talking about the preferred. So the preferred one is the stimulant laxative. However, the other ones can still work. There's two softeners, the osmotic laxatives. But you avoid the bulk forming because with all the other ones, the bulk forming require peristaltic movement before they exert their laxative effect. So they swell up the fecal mass and all that. But after everything, they require peristaltic movement. But the stool softness, they've made the stools too soft. So it depends on the patient. So once the stool is soft, it can easily be passed, even with very little peristaltic movement. The osmotic ones too, they draw up water into the gut. So the stool is made soft. And the stimulant laxative actually stimulates or activate the colonic nerves. That also help with peristaltic movement. But with the bulk forming, once they've swollen up the fecal mass and all that, you need active peristaltic movement to propel it. If there is no active peristaltic movement, it will end up blocking the intestine.
Yes, please. Thank you. (15) Ideal laxative for fecal impaction with hard stools. A. Senna. B. Psyllium. C. Disacodyl. D. Macrogol 3,350.
Okay, so which one are you going for?
D.
Okay, I'm hearing D. Any other answer? Yeah, so the D is correct. The patient is having fecal impaction because the stools are hard. So from the options there, the one that softens the stool is the macrobol. It's an osmotic laxative. So to draw water and make the stool very soft.
(16) Ideal laxative for fecal impaction with soft stools. A. Docusate sodium. B. Glycerol suppositories. C. Bisacodyl. D. Macrogol 3,350.
Okay, which one are you going for?
C.
Okay, so I'm hearing C. Any other answer? So C is correct. So fecal impaction, you can have fecal impaction with hard stools or fecal impaction with soft stools. So it depends. So if the stools are hard and there's fecal impaction, all that you need to do is you have to give something that will soften the stool. Once the stool is softened, patients can easily pass the stool. However, if you have fecal impaction and the stools are soft, what this means is that the fecal impaction is not because of the stool consistency, because the stool is not hard, but the issue is because of the inability of the person to evacuate the stool. So you need something that will stimulate the intestine to cause active peristaltic movement. So you want to give a stimulant laxative when there's fecal impaction with soft stools. However, you want to go for a stool softener when you have fecal impaction with hard stools.
Seventeen. First choice of laxative for a pregnant woman: A. Liquid paraffin, B. Bisacodyl, C. Methylcellulose, D. Senna.
Okay, which one is first choice?
C.
Yeah, so C, methylcellulose. So we mentioned the bulk forming laxatives are usually non-absorbable. So for pregnant women, yeah, concerned about anything that will be absorbed, get to the fetus and cause harm. So the bulk forming laxatives are usually safe and the preferred first line.
18. Tolerance can develop against all these opioid-induced side effects except A. Respiratory depression, B. Constipation, C. Sedation, D. Pruritus.
Okay, so which one are you going for? Which one are you going for? So you do realize that for the opioids, one of the issue with opioids is tolerance. So the same way you develop tolerance to the analgesic effect of opioids, you can also develop tolerance to the side effects. So for example, if a person was taking 5 milligram morphine, and that 5 milligram morphine initially could manage their pain, with time, if they continuously take that 5 milligram, it will get to a point in time that 5 milligram wouldn't be able to resolve the pain. So they may need to go up on the dose to maybe 10 before they can start getting the analgesic effect. The same way, patients could also develop tolerance to the side effects. So maybe at a dose of 5 milligram, it was causing sedation. They were getting that sedative effect of morphine. But with time, they take 5 and they are still awake. They are not sedated. So they may need to go up on the dose before they can get sedated and all that. So of all the side effects there, it's only constipation that you can never develop tolerance. So if that 5 milligram was causing constipation, if you continuously take that 5 milligram, it will still cause constipation. So that's why we realize that for a lot of these oncology patients, because they are on morphine, they usually prescribe a laxative in addition to the long-term morphine they are taking, the chronic use of morphine, because you can never develop tolerance to the constipation side effect. So you just have to manage it. So that's why laxatives are usually added to the opioids for these oncology patients.
19. Why is it preferred to give bisacodyl tablets at night, but the suppositories in the morning?
So why is that so? That you tell a patient when you are prescribing the tablets bisacodyl, you want them to take it at night, but the suppository, they can even take it in the morning.
Bisacodyl takes the bisacodyl tablet takes time to work. Thus, it takes between 6 to 12 hours to work. However, the suppository has a faster onset of action. Yeah.
Have a fast relief in the morning. When you take the suppository, within 15 to 60 minutes, it's already working. So when you just wake up, you insert the suppository. In the next 15 to 30 minutes, you start having the laxative effect. However, for the tablet, it has to be at night so that you get the effect in the morning.
20. Which of these medications is less likely to cause constipation? A. Amitriptyline. B. DF118. C. Atropine. D. Erythromycin.
Hello, Doc. Please, I didn't hear the reason for why bisocodyl is taken at night.
So I was saying that bisacodyl. Hello.
Hello, sir. Please, we can't hear you.
Yeah, so I was saying that bisacodyl. So I was saying that bisacodyl tablet, the onset is 6 to 12 hours. So if you want the effect, if you take it during the waking hours in the morning, it affects your day's activities because the onset is 6 to 12 hours. However, if you take it at night, it coincides with your waking hours. When you take it at night, maybe you took it around 8 p.m. or 9 p.m. When you wake up in the morning, maybe around 5 or around 4, that is when the onset would have kicked in. So you just free your bowels before you start the day's activity. But if you take it in the morning, maybe around 6, you took it. In the afternoon, around 12 or 1, that's when you start having the laxative effect. And that's during the working hours. So it's preferred to take it at night so that in the morning you have the laxative effect. However, if you need something quick onset in the morning, then the suppository, because the onset is 15 to 60 minutes. So the moment you insert the suppository, within 15 minutes to 60 minutes, you can start having the laxative effect. So that's why it's recommended to take the tablet at night, and the suppository, it can be in the morning.
(20) Which of these medications is less likely to cause constipation? A. Amitriptyline. B. DF118. C. Atropine. D. Erythromycin.
Which one are you going for?
D.
I heard B. Is everyone going for B?
D.
D. D.
Okay, so D. Yeah, so erythromycin. Erythromycin is more likely to cause constipation, diarrhea instead. Remember, we talked about motility diarrhea, that erythromycin is able to stimulate the motilin receptors in the gut, and that can increase intestinal motility. So erythromycin tends to do diarrhea, but the rest will do constipation. What is DF118? What's the active ingredient of DF118? Anyone?
Dihydrocodeine.
Yeah, so dihydrocodeine. So if you don't see DF118, it's the same as dihydrocodeine.
21. Which of the following laxatives can be used in managing hepatic encephalopathy? A. Docusate sodium. B. Bisacodyl. C. Rifaximin. D. Lactulose.
D. Rifaximin. C.
Which of
D.
them?
200.
D. Lactulose.
Okay, I was hearing rifaximin.
So please, sorry, rifaximin is for traveler's diarrhea. Sorry, D.
So it's D, lactulose. So we can use lactulose for hepatic encephalopathy. Rifaximin can also be used, but it's not a laxative. Rifaximin is actually used in treating diarrhea, not for constipation. Okay. So that's the last question, right?
Sir, please, could you go over the question 1 to 3? I couldn't join earlier.
So question 1, we said the answer is psyllium. We said the answer is cascara, sorry. So which of them? All of them are bulk-forming laxative, except cascara. Cascara is a stimulant laxative. So the rest are bulk-forming. Then the question 2, we said the answer is hyperthyroidism. Hyper causes diarrhea. Hypo causes constipation. And the question 3, we said the onset is not up to 24 hours. It's up to 96. So the answer is A. All right. Do you have any more questions? So that will be the end of our discussion on the constipation. So we'll start a new topic, hopefully the next time that we meet. If there are no questions, we end today's meeting. Have a good evening.
Yes, please. Thank you very much.
Have a good evening.